Good afternoon and welcome to this week's edition of Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, and streaming on Facebook Live. My name is Eric Marsh, Executive Director of Whitewater Community Television. Thank you very much for joining us for another Ask the Doctors. Our doctors, they're with us this week. Congratulations. I guess the snow this week kept you all from going anywhere. You didn't have to go to out west to find snow. You found it here?
No, it came to find me. I went out and made a few snow angels in the driveway and then came back inside by the fire.
Dr. David Jetmore, Wayne County Health Officer. Dr. Thomas Huth, Vice President, Medical Affairs, Reed Health. Gentlemen, once again, we appreciate your time. It's been a quiet, uneventful week in your lives as far as COVID goes, question mark. And I'll let whoever wants to jump in and laugh at me. Go ahead.
We haven't had any more deaths. We had those 2 deaths last week. Our positivity rate here in Wayne County is still low, but it's steadily going up. We're up to 3.5%, which compares to 5% for the state. So we're doing better than the state. We've got 18,772 people that have been fully vaccinated, which gives us a vaccination percentage of 35%. 35.3. We need all the decimal
points. We need everything we can get, huh?
And we need to push that number forward. We've got plenty of vaccine, and I think that's also true for Reed at their site. And we need more takers. Our immunization clinic hours are Tuesday, Thursdays, and Fridays from 9 to 4 p.m., 9 a.m. to 4 p.m. And walk-ins are welcome, or you can go to rshot.in.gov and schedule an appointment. If there are any groups in the county that want to be vaccinated, you can call the health department and we'll arrange to bring our mobile unit to that group. I mean, it can be a group as small as 20 people. We'll come out and vaccinate that group. And the number for the health department is 765-973-9245. So I think the message for this week, like it was for last week, is we've got plenty of vaccine now, but we need more shoulders to put that vaccine in.
You've begun using the mobile unit that you all purchased. How has that gone as you have taken that out and literally tried to make it easier for people, taking it to locations?
Yes, but it's been, our hopes were, I'll give you a couple instances. We took that mobile unit to Hagerstown with plenty of doses and gave eight people showed up for vaccinations. We took it to a factory that has 500 workers and gave 70 vaccinations out of the 500. So there's a lot of, there are many, many people who are not coming forward to get the vaccine for a number of reasons. But that's the tough part now, is to get people to get vaccinated.
That 35.3%.
We want to count that 0.3.
That we have hit seems to be kind of a number that's out there. I assume from there you all aren't seeing as many people as you would like either.
No, I think that's a very consistent theme around the state. We were on a phone call Wednesday with the State Department of Health, all the hospitals and health systems that are doing vaccination centers, and pretty much everybody who chimed in was telling a similar story. There's a big center in Terre Haute that Parkview Hospital runs. They set up one of the largest programs in the state, and they have been utilizing like 1/5 of their capacity lately, and that's been dropping precipitously. And that was precipitously was the word that their medical director used in describing the changes. And at the Kuhlman Center, we had a couple of relatively high days for us, around 300 vaccinations, but a lot of those were second vaccines from back when the age dropped down to 16. But in terms of new vaccinations, which are really the key for going in terms of building estimates for what it looks like going forward, we've been in the in 10 to 15, 20 a day. I think we had 30 the other day, but that was, that's just nothing like the numbers that we're built for and capable of doing. And consequently, we're looking at ways to utilize our system of offices to see if we can start giving those shots in doctors' offices. You would think that would be a simple thing, but it's not because of the multi-dose vials of the vaccine. We happen to use Pfizer, which has six doses per vial. But once those come out of freeze and are prepared for use, they have to be used within a very short period of time. And so we've got to go to places where we know that we can use those up in order to avoid wasting them. That's the challenge with getting them in a more distributed fashion. But we actually have I would call it a soft launch of being able to provide those in our urgent care centers, one in Richmond on Chester Boulevard and one in our Connorsville facility. Those are actually being done now. You can access those if you go to sign up. You'll see those opportunities on the state's website for scheduling these. And we're going to look at implementing it in some other places as well. So we're trying to figure out how to achieve several things at once. One is to kind of match our resource commitment to what the demand bears, because it doesn't make sense for us to really staff up the Kuhlman Center and to use all that space and have six vaccination stations and all the resources that are committed to that when only a handful of people come in every day. So therefore we're going to try to use other means and figure out how to make that work. So we're experimenting with that now. I just wish more people would come and take advantage of the vaccination. We know that there are lots of people who could and should, really. I mean, I think to me, from a medical standpoint, the evidence is becoming clearer and clearer all the time that these vaccines, Pfizer in our case, Moderna in the case of the health department, they're very safe and effective. There are remarkably few problems in there. And these two vaccines happen to have the highest efficacy rates of the products that have been approved in the U.S. We were maybe hoping that Johnson & Johnson would get released soon, but we're hearing today that there are some new cases of severe complications, possibly from that particular vaccine, that are being investigated. And there had been a hope that the FDA would release those again for use beginning tomorrow, but I'm not sure now that will happen, given a couple new cases of women who've had severe complications, and one of those involved a death. But we do have to keep in mind that that seems to be very specific to that vaccine. The other vaccines, the Pfizer and Moderna, have now been used something like 200 million times. In terms of shots, it's not number of people vaccinated in the U.S., but 200-ish million shots given, and nothing like this happening with those. And I think we would know that by now if those particular ones were significantly involved with that particular complication. And that's a tremendous track record, and they're very effective. And some more people ought to be thinking about, who can I protect by protecting myself? We all have people in our lives who are at risk. Maybe we're a primary caregiver. We're a caregiver for somebody who's particularly at risk, and or just things that we go out and do in our everyday life. We're going to come in contact with people who are at risk, and I think we have to get back to understanding our responsibility with that. There were a couple of interesting studies published this week in the Morbidity and Mortality Weekly Report. That's a CDC publication for the healthcare provider community on all kinds of topics. But these two reports were involving what they're calling breakthrough infections amongst people who've been vaccinated. And it shouldn't come as a surprise to us that it happens. We sort of been expecting this, because even the Pfizer and Moderna vaccines had 95% efficacy rate, which is tremendous. But that means some people are not going to get the protection from them, And so there is the opportunity for those to break through. These breakthrough infections happen to be centered on nursing homes, which in one report it was a grouping of nursing homes in the Chicago area. In another report it was a particular facility in Kentucky. And, it points out several things. One is the vaccines are not perfect, but they're very good, but they're not perfect. These people tended to have, the people who were vaccinated in the outbreaks, who had been vaccinated, tended to have less severe disease, but they still could get sick. That the people who come into contact with the residents of these facilities had very low vaccination rates, and clearly they're sort of the route of introduction of virus into the facilities. So we can't count on vaccinating the most vulnerable as the means of ending the threat. They may get incomplete immunity. Some may get very poor immunity from vaccination due to their underlying conditions and age. And those people who are working with them need to take responsibility to vaccinate themselves to protect them. That's a lesson from that. Also, there's a lesson in there about variants. In the Kentucky case, they did some genomic sequencing of the swabs, and they're a very rare variant was involved in that outbreak, the so-called R1 variant. I've been trying to look up why haven't I heard of this R1 before? Where does it come from, and what's its history? And there's very little information out there about it. So we'll probably learn more about that over time. So variants are a lesson in here. They can be a reason for, breaking through vaccination. And in the Kentucky case, three residents died. Two had not been vaccinated previously. One had been, and so getting vaccinated is not an absolute block. So you have to layer on the defenses, and that really, to me, that most fundamentally involves all of us taking responsibility for our potential to transmit to others. Oh, there was another lesson in there, which was, when they have an outbreak in a nursing facility, they begin a series of regular testing of everybody, staff, residents, multiple times over a period of time. And so they detected a lot more cases, but a lot of those were asymptomatic. So asymptomatic spread is still an issue with all of this. And, so we, the things are looking a little bit better in the U.S. When we get to the statistical portion of the program, I will demonstrate that, and you can see that in the numbers. The world is still having actually a very high upward trajectory. It's driven almost completely now by India, which is a huge nation, going on 2 billion people. Very poor country overall with, not a first world healthcare system. And so things really are looking very bad in India, but it's the other side of the world. It's not us, and we've got other things to think about, so it's kind of out of people's minds. But the point is that there's a lot of, people from, India has lots of interactions with other parts of the world. There's no reason at all to think that it is going to stay in India. So we have to be very concerned about that. But admittedly, the numbers in the U.S. are looking slightly better. We had been worried about a slow burn upward trajectory, but in the last week that's been, seems to have rounded over a little bit. So that's good. And, and we've got a few more cases in the hospital now, which against not big change, but it definitely is a little bit of an upward trend in hospitalizations over the last couple of weeks that we can see in the data. So I think that we're not done with COVID by far, but I know everybody's tired of it and they'd like to get on to other topics and, move on with life. But I always have to go back to the point, with major worldwide pandemics, the last big one really was the Spanish flu epidemic in or pandemic in 19, we call it the 1918 pandemic, but actually it lasted the better part of 3 years with multiple waves. And, you know, I would like to think that we can escape the severity, and we should be able to, but I think we just have to be prepared for this to last a while.
Do you see?
You know, just to interject,
Go ahead.
Tom talked about India and about how it's on the other side of the world, and it's easy not to think about it, but with plane travel, you know, with these, whatever variants are in India are going to appear here. But, you know, the highest incidence of COVID in the United States is our northern neighbor that we share a border with, Michigan. And I was looking at that COVID map today. You know, a few weeks ago or more, everything was blue, and the state rates from the least amount of disease, blue, then yellow, then orange, then red. And all the counties along the Michigan line, 2 or 3 deep, are yellow or red. So, and they're dealing with that variant from Britain, the B.1.1.7, which is very, very contagious. So it looks like that variant is heading south toward us. The central and southern counties are still blue, a few yellows, but that northern part is all yellow and orange.
We talk about how to get more takers for the shots. Are we at the point now in your minds where it's not about those people that are willing to do it voluntarily, or even worrying about those people that will never do it? There's people that will just never do it. They don't take any type of vaccine. Is this an education thing now? Does the idea need to turn more toward educating those people who are on the fence and making them comfortable? And is it possible to do that? Is there something different we can say? Is there a different way to say it? Do we need to consider where people are and what they're facing as we talk to them, as medical professionals talk to them about doing this?
Well, I'll speak to that, and I know Tom probably has comments too. I've talked to people like this and asked them why they weren't getting vaccinated for various reasons, and tried to point out the myriad of reasons why they should get vaccinated. And I was not really able to persuade a single person to get vaccinated. Everybody out there that's unvaccinated have heard these messages. We can keep continuing with that. The one country that's kind of gotten ahead of us is Israel, who's vaccinated, I think, 65% of their citizenry. And now nobody wants to have vaccines. So what they've done is everybody that's been vaccinated, you get a green card. And if you've got a green card, you can go into a restaurant and eat. You can go to a gym. If you don't have a green card showing you're fully vaccinated, then you just can't do that because of the fear of spread of COVID. So that's how they solved the problem. They realized that these people were never going to get vaccinated, so they have excluded them. I'm sure there'd be a huge outcry here if that happened.
Well, you've got states, Indiana included, that are passing legislation that won't allow government organizations to put those type of things out. So now all of a sudden you would end up with various business entities trying to do that, and you've already got how many cards in your wallet? How many more do you got? One for this business, one for this business.
Yeah.
How do we make this work? We're heading into summer. People are not, and you already know it, people are not going to spend another summer not traveling. Between the traveling sports teams and people just finally wanting a vacation, they'll be out there. Are we in your 3-year 1918 cycle where that's the way it is now for us?
I don't know. I hesitate to try to predict the future too much. We can only try to draw some lessons from the past. I think that, but Well, we have a different notion of civil rights in the U.S. compared to, say, Israel, and that's not to put down Israel at all. So, there may be things that they can get away with there that would be harder in the U.S. for a lot of reasons, including, is it constitutional or not? And that's where the politicians are having those arguments, and yeah, we see jurisdictions, state governments, and whatnot, sort of outlawing vaccination passes and so forth. But, nevertheless, I think there's an argument to be made that there are some people who really should do it, who should be more or less mandated to do it. And I think particularly of healthcare workers, particularly those who work with the vulnerable elderly. You could make an argument that it should be mandatory, either from a government action or the industries involved ought to make it sort of standard procedure to vaccinate their staff. I mean, I got to go back to, we know that at least the Pfizer and the Moderna vaccines are very safe and effective, and that when they're taken, they work. That's how you get your maximal protection. Let's put it that way. That doesn't mean they're foolproof, because they're not, but I think we're getting close to the point where we're kind of like influenza vaccination. There are hardly any health systems, hardly any nursing home systems that don't require flu vaccination for their staff, and it's for a very simple reason. They really are actually pretty safe, and even though the effectiveness rate is lower, we know that when the staff particularly get vaccinated, the likelihood of outbreaks are very low. I've seen that in my own practice, where I do work in nursing homes with the vulnerable elderly, and we'd have years where almost 100% of the residents of facilities would get vaccinated, yet there would still be outbreaks. But once the nursing home system mandated flu vaccines as a condition of employment, and almost everybody got vaccinated amongst the staff, the flu outbreaks just absolutely stopped. And I think we'll have the same thing with COVID. And I've been involved in some discussions with leaders in that particular industry, long-term care, about what should be advocated for. And I think we're going to go to a time in the not very distant future, at least by the time either of these vaccines receive full FDA approval. I don't know when that will be, but at least by then, I think we'll see that health systems will more or less mandate their use, make them conditions of employment. They have to make reasonable exceptions and things to be in compliance with labor law and Equal Employment Opportunity Commission regulation and stuff like that. But, I think we're headed to that, where maybe some key industry folks will really have to get vaccinated. There'll be people who work in healthcare, people who may be first responders to protect themselves, if nobody else, and their families. People who work, say, in sanitation industries. It's actually kind of amazing, all the infectious diseases that are present in sanitation, and I know that that's an area of focus by public health to really kind of protect those folks and prevent spread of diseases from sanitation systems. I think we'll see kind of maybe like an industry or profession focused, more or less mandatory use of the vaccines going forward at some point. But I think that's probably the American way to do it, rather than to mandate everybody get something, or to restrict your travel on account of it forever.
But that travel will end up being restricted by other countries at some point, I assume. I mean, if Israel has made a passport for their citizens, you can imagine that they would be a little hesitant to allow someone to come in that hadn't been vaccinated. So I assume that will begin to, over time, push the envelope for more people, because travel is something that we like to do.
Yeah, the interesting thing really is that it's hard to find cases where people spread COVID-19 on airplanes. I mean, you can find cases where people traveled and then spread where they got to. I think the airline systems have done a great job of making their environment safe. But part of that is that in some cases you have to, like particularly if you're going to a foreign country, you today have to get tested for COVID-19 within a certain period of time before you travel, and then again when you get there. I think we'll see that it'll probably be destination driven as to what the airlines are going to require you to do or to prove that you've been vaccinated and so forth. I think they might be doing that they're considering that in England, that travel from certain places you either have to be tested or have to adequately prove that you're vaccinated before they'll let you come into the country, as an example.
Want to weigh in on? You're
Yeah,
probably of the three of us in the room, you've probably done more traveling than
I love
any
to
of
travel.
us.
I probably miss that more than anything since this pandemic started. There's tremendous precedent for requiring people to get vaccines. For instance, if you're going to go to sub-Saharan Africa or if you're going to go to South America, you're not going to be able to get a visa for those countries unless you've been vaccinated, say for yellow fever. So countries have the right to do that and will do that, and I think Tom's right. I think you're going to need to have a card in order to travel to these various countries. Or, I normally have a vaccination card that the customs agent can look at on entering the country, and it has all the vaccination official stamps and signatures, and they'll require COVID along with yellow fever and all of the others. But I think that'll be something we'll see in the future,
Yeah.
probably the near future.
Well, I think Notre Dame may be the only college at this point in the state of Indiana that has, I want to say, mandated that their students coming
Yeah.
back in the fall actually have to be able to prove that they've been vaccinated. So
Yeah,
they're trying
I
to get a
think
lot of them before they even leave this spring. And we'll have to see how far that actually spreads through the educational system, particularly those residential campuses where people are coming literally from all over.
Yeah, absolutely.
You're watching Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, streaming on Facebook Live. Thank you very much for watching today. We are taking your questions on our Facebook page as well as on Twitter at WCTV Info. I know that we've had some questions already come in, so let's we've kind of gotten through this a little bit. Let's see what your questions are. Will it ever come to, and we've kind of just been talking about this, will it ever come to forcing everybody to get a shot?
Well, it's probably, it looks like a simple question, but it's more complex than you would think. First of all, Tom alluded to this earlier, the vaccine is under an emergency authorization by the FDA, and so it's hard to mandate somebody to get a vaccine for emergency use. Although, 200 million people being vaccinated, that's a pretty good survey that it's a safe vaccine. Nonetheless, it's not gotten full approval from the FDA. So I think no one's going to be mandated or forced to get this vaccine until that particular piece is in place. But having said that, I think that once it has full FDA approval, I think many employers will require their workers to be vaccinated as a condition of employment. And, there's plenty of precedent. Tom and I, we have to get a flu vaccine. We're healthcare workers every fall as a condition of our employment. Mm-hmm. So there is precedent, and I would think that will probably happen.
Yeah, and but I at the same time, I kind of alluded to it with, the sort of the American way of doing things. I'm not sure that we'll ever. I can't say never, but I'm not sure we'll ever be in a situation where every American will be mandated by the federal government or somehow to get COVID-19 vaccination. I think it will be more sort of industry driven. And, flu shot's just one example on healthcare. I mean, to me, the shots are no big deal. The COVID-19 shots were the easiest shots I ever took. But I've got to get a flu vaccine every year. I've had to have hepatitis vaccination. And I have to be tested to ensure that I've still got antibodies periodically. And I have to be tested and evaluated for, tuberculosis infection, and they make sure. And I have to get certain other vaccines like the tetanus, diphtheria, pertussis combination one, periodically. So, this is really not that big a deal. And there are many other industries where that's the same thing. I refer to sanitation. They've got to have all their shots and things to protect them. And so I just feel like we shouldn't get too worked up about whether one day COVID-19 shots will be mandatory for some situations, because there's lots of precedent for that.
You've both mentioned at various times the emergency authorization use that both the Pfizer and Moderna are under, and you're looking for those to be fully approved by the FDA. As someone who doesn't normally watch how long it takes for a vaccine to be approved, what is kind of the average? I know you can go either way with some of this. What is kind of the average that you all have seen that it takes for a vaccine to get that full FDA approval? I mean, are we within a year of what would normally be? Are we 5 years out from what would normally be? And I'm asking that question because that is part of, I think, some of the hesitation that I've been hearing, at least, that these things have come through much more quickly than other vaccines. If they had taken a little bit more time, some people, not all, some people might have felt more comfortable with them.
I'm sure that's true. But there are some people who still object to having flu vaccines, So I'm not sure I'm not sure how many people really that would improve their outlook on it. As far as how long it will take the FDA to get around to doing full approval of the Pfizer and Moderna vaccines in particular, and my guess is those will be the ones to get them first, obviously. Mm-hmm. I think it will happen sooner than it would kind of with a normal pharmaceutical, which can take, 5-10 years. It will happen sooner because the FDA will consider a lot of the data that's already being accumulated. There are tens of millions of people who've been vaccinated already, and there's a certain amount of data that's available from that. That will be included. Plus, they'll use some of the expedited mechanisms to get to that point, I'm sure. And that doesn't mean they're cutting corners. It just means that they're allowing, like one of the ways that they got the two vaccines to this point was they allowed the phase 1 and phase 2 studies to be done simultaneously. Normally those will be done kind of sequentially. And so there are different ways that doesn't cut corners, but because they can concentrate resources on getting these ones done, they could do them faster. And I think that's what they'll bring to bear for the full FDA approval. There are some questions that the FDA wants answered, and we know of a few of them. There may be others. They want to see the data that they're safe to use in children, as an example, or that specifically they're safe to use in pregnant or lactating women, as another example. And there are just particular focus groups that have always been high priority to have particular study on, but those studies are happening now. So, and I don't know when we'll have full FDA approval, but I wouldn't be surprised if it could happen for one or the other in a few months. There is precedent for that with in the COVID-19 realm, not with a vaccine, but the remdesivir, which is an antiviral drug that we're using in the hospital for sick enough COVID-19 patients. That was originally released on an emergency use authorization, and then within like 3 months it was fully approved. And that was an unheard of rate at which a drug got full FDA approval. And so, I think it's just that's an example where with the right prioritization of getting the data done and in, I think it could happen fairly soon.
You're watching Ask the Doctors on WGTV Channel 11, CTV Channel 21, streaming on Facebook Live. We're taking your questions on Facebook. We're also taking your questions on Twitter. Let's go to our next one. Is there a date yet set for the Coleman Center downsizing or discontinuing vaccines there, especially for people waiting to get their second dose?
We're propagating out the vaccination effort to other sites, as I mentioned before. We're looking at the resource commitment we have to the Coleman Center operation. And I think part of but there are no dates yet set for anything, and we'll be working on that over the next week or so and hopefully have more information maybe next week this time possibly. But I think the thing to keep in mind is that people have to use that resource. But we have to look, and that's driving some of the consideration now. Can we really commit all those resources to that if this is the way the demand is going to be? But I think the thing that we also have to consider is that probably at some point there'll be a need for a revaccination. The Pfizer and Moderna CEOs have both said so. The CDC and FDA have been kind of tight-lipped on the question. But I think Dr. Fauci has said that he thinks that will probably be necessary, and it just makes sense, common sense, that that'll be the case as variants come more into the picture. And we've already made some adjustments in other therapies on account of the information from the variants, the rise of variants, thinking there particularly of the monoclonal antibodies. But that's the point, is that at some point there may be a need to re-implement large-scale mass vaccination. And, so we want to be ready to do that. So we're trying to think, how can we fine-tune our resource commitments to what the demand is today, but be, able to respond to the need should there be a big outbreak again and there's a lot more interest? Should we need to do revaccination? Should there need to be new vaccinations even later related to COVIDs or to variants? All these are question marks that we have to figure out a plan that takes all of it into account. So I don't have anything to talk about today about what's going to happen with the Coleman Center in the short or long run. As it stands now, we are in the Coleman Center, but going to do some things in other places to make it more convenient for access.
Health Department has already made some changes. At one point, it was a 5-day-a-week. I think at the Elder Beerman Center, you all are down to Tuesday, Thursday, Friday. Have you all continued to have discussions about maybe being able to pull back even more out of that Elder Beerman facility?
Yes, as Tom says, you put tremendous resources into these clinics. And if only a few people show up, then, that's why we've contracted back from Tuesday, Wednesday, and Thursday. We're hopeful to use Mondays and Fridays to send out our mobile unit to other towns, more in western Wayne County or to the north in Wayne County. And if there are any kind of special groups or factories or anywhere, any kind of a grouping, we'll go to them with our mobile clinic and we'll vaccinate those people. But with with the number of people wanting to be vaccinated shrinking, those resources will have to be pulled back because they're expensive. They involve a lot of manpower.
Okay. Next question up. With the Johnson & Johnson vaccine being paused, does Reed or the Wayne County Health Department have any concerns about Moderna and Pfizer vaccine shortages in the near future?
Well, we kind of addressed that earlier. We're up to our necks in vaccine, and we need more shoulders to put that vaccine in. So I don't see a problem with a vaccine shortage in the near future.
Correct. I mean, it's the same thing for Pfizer. There's plenty of it in the state. The state is having trouble finding enough places to get it out. Fortunately, it will keep for a while longer, so we're not worried about a lot of it expiring. But, the state is encouraging all of us to do more things to try to get more shots out. But it's as we're finding out as we try different things, there's a limit to how much we can get at any one time. So there is no shortage of either Pfizer or Moderna now. There doesn't appear to be shortages on the horizon. Their manufacturing processes are up and going, and they're delivering lots of vaccine. The problem now is getting people to take it.
Okay. We're going to get one or two more questions in, and then we'll get some information update this week from Dr. Huth. Let's go with the next one. What kind of impact are we seeing with the masking requirements being relaxed? Are cases on the rise? I know you mentioned a little bit up north.
Yeah, well, cases are on the rise, but they're not rising precipitously. I mean, they're not heading straight up like they are in India. But we see incremental increases every week. You know, a few weeks ago we were 1.8%. Then we went to 2.5%. Now we're at 3.5%, which is a low positivity rate. But nonetheless, it's slowly trending upward. Now, I don't. It's difficult to tell why that is. The only thing that's changed in the interim is there are fewer people wearing masks. So that may be playing a part in that, but you can't say that with total certainty.
Yeah, and I'm glad the question about masks came up because that's still an area where we see some mythology. I'm kind of getting off track from the question. I guess the short answer to the question is, you know, it's hard to draw one-to-one correlations. I think we have to allow for a longer period of time and kind of see what impact there is over time. Mm-hmm. But there is still mythology out there about mask wearing, and what's been circulated very widely this past week is a bogus quote-unquote study. It's if people see it in social media or emails, usually it's said, here's a Stanford University study that debunks the usefulness of masks, is basically the headline on it. Problem is, the publication that's referenced is a pseudoscientific publication. It's not a real scientific publication. It's published at a website that publishes stuff that is not peer-reviewed, and they'll just take anything. And so and they state in their purpose that they're just there to allow people who want to propose radical, different ideas from what the medical establishment says, here's your outlet. And the individual on it calls himself who wrote this article that was strictly an opinion piece, had no science in it, or cherry-picked articles that don't tell the whole story, but it was really an opinion piece. That individual says that he's affiliated with Stanford University, but Stanford University has totally disavowed any association with the individual. And he says that he works in cardiology, but actually it's a real person apparently, but he's an exercise physiologist who works in Israel. Nothing wrong with working in Israel, but it's what is purported to be the case with this study is not the fact that also, despite its headline, a Stanford University study on masking is neither about mask, and it has no affiliation with Stanford University. So I just want to alert people that this is out there. It's being widely circulated this week. There are lots of refutations of it. You can find one on Snopes.com and some other places. But great. Thanks, guys, for showing that. That wasn't even my thing. You came up with that real quick. So, you know, we all have to be alert to these little scam things that run around, and this is one.
Okay. Last question before we turn to you for some updated information this week in your charts. Can the COVID virus spread through water in pools, hot tubs, or water playgrounds?
No.
I'm not aware of any evidence of that. You know, I think we believe that chlorine's a pretty effective disinfectant for COVID-19 virus, and all these, you know, if you're managing your pool water, if you have a private pool, but certainly the public pools and water playgrounds, they have very carefully managed water. So if if it meets current sanitation standards for pool water, it should be just fine.
Sounds like you just said the pool's opening this year.
Yeah, I think we know so much more about COVID than we did a year ago. And one of the things was, one of the things we have to come back to is this is a respiratory disease. You have to breathe this virus in order to, and you have to breathe in essentially an infective dose to become infected. People in the swimming pool they're going to be outside. Certainly, I'd be more concerned with an infected and non-infected person talking face to face for half an hour than anything to do with COVID in the water.
Right.
Which reminds me, I read a article the other day saying that there's not been any reported major outbreak in people when they're outside. I think when you're outside, the viral particles dissipate so quickly that the danger is really minimal. And the one article they cited, and this went back to when right after the virus broke out in Wuhan, these two friends were talking on a terrace outside. One of them had COVID and one didn't. And they talked for about an hour face to face, and the other person got COVID in the open air. But I think with summer coming up, I'm hopeful that a lot of us will be outdoors, and the disease may well switch to the south where people are crowding indoors into air-conditioned rooms, but pretty safe when you're outside.
I think those kinds of things are sort of they're not a matter of, safe, unsafe. It's really kind of a spectrum of that, and on the spectrum being outside, particularly if there's good airflow and so forth, that they're relatively safe compared to other activities. And a corollary to that discussion is I've noticed a lot of commentary on whether indoor air standards ought to be changed from an engineering standpoint about air handling systems and so forth, even in residential dwellings, because a lot of houses, private homes are very, very highly sealed up these days for energy efficiency, and air handling systems don't necessarily change over using outside air at a rate that we think is better for reducing the transmission of COVID-19. And so I think some jurisdictions, like building code jurisdictions, are thinking of changing the building code standards so that there's more outside air exchange. But it goes back to that discussion of, the thing is the airflow, the air exchange, the dilution factor of fresh air is important in reducing the chances of spreading COVID-19. But, you can defeat all that if you've got somebody who's infectious and somebody who's not, and they're sitting very close together for a long period of time, in an alcove or something that's not as air flowing, so you can find ways to overcome all that. But but to Dr. Jetmore's point, it's relatively safe and appears to be actually quite safe to be in outdoor environments. But, on the other hand, if it's a big concert with a lot of people sitting together, maybe that's a relative argument against that particular activity, even though it is outside, just as an example.
Okay. We've got about 8 minutes or so left in this week's program. Thanks for watching this week's Ask the Doctors, by the way. We'll turn to Dr. Huth right around this time and ask him to show us some of the latest numbers.
All right, if you start with the first page, and I brought, there's a lot of stuff on here. I just want to focus on a couple of aspects. One is the curve that's sort of on the right side. This is the world cases, and it's just the height of the total curves. This is a series of stacked bar charts. Don't worry about that for the moment. It's really the overall look, and you can see that overall, the world cases are actually on the point of exceeding previous high over the winter, over our winter. And what's really driving that is the purple section. That's on here. It's the World Health Organization zone called Southeast Asia. But what I'll tell you is that is India. India is the largest country in the Southeast Asia section and of the world in the way that the World Health Organization divvies up the planet. And so that purple bar, set of purple bars is virtually all India, and you can see that their rate of increase is going vertical, and that's not a good thing. To go on to the next one, this is, if you could zoom into the upper right-hand part of that graph. I brought this one before, and the gray one, if you look to the very right, the gray line is the average, sort of the U.S. average, and you can see that it is at a certain point. Indiana is the green bar that's right below that. So, and then Michigan is the highest rate in the country. Dr. Jetmar referred to that a while ago. And the thing to point out here is that actually in the last week or so, these rates have all kind of turned over a little bit. We hope that that indicates a new trend in the downward direction for the country and for Michigan particularly, and for Indiana. These are the rates per new cases per 100,000. I guess I should specify that. So right now we seem to have turned over a little bit. What that means for the future is a little bit hard to say because the numbers are going, the lines are going to wiggle up and down a little bit. Hopefully that means there's a new trend in the offing, but I don't know. But I like to point that out because I don't want to all be doom and gloom when we come in here. The next page is the Wayne County numbers, and this is just the last, I don't know, 6 or 8 weeks, 9 weeks maybe. The last bar on the right is the current week in progress, and through data through the 22nd, which is now, it's not the very latest information. There could be more cases, but it looks like we'll end up the week around 32, which would be a decrease in just the absolute case count. That's a different thing from the positivity rate that Dr. Jetmar referred to, but because that has 2 factors. That has the positive cases and a number of people being tested. So this is just the number of cases, and hopefully we'll start a new downward trend or at least stay flat in Wayne County going forward, but we'll just have to see. The last is kind of a similar time frame, maybe a little bit longer. These are daily rates at Reed Health for the last 4 weeks, and this is the only kind of a cloudy spot on the whole thing because I brought it on a daily because we can see over the last 4 days we've actually had some sequential increases, which is not what we want to see. But when we think about it, increase in hospital cases and so forth is kind of a late manifestation, because it takes a couple weeks to go from having an infection to, or at least a week, to needing hospitalization. So I hope this does not represent a new upward trend for the volumes at Reed, but we'll just have to keep a close eye on it.
Okay. We've got about 4 minutes left on this week's Ask the Doctors on WGTV Channel 11. We're going to see if we can get 1 or 2 more questions in before we bow out. So, is it safe for people with autoimmune disorders to get this vaccine?
Yes, it is. And in fact, somebody with an autoimmune disorder is a prime candidate to get the vaccine because they're more at risk from COVID-19 infection. I like to say the choice here is not get vaccinated or not. The choice is get vaccinated or get COVID-19. One of those 2 things is going to happen to you eventually. That's the simplest way to break it down for people. So we need to think about this in terms of, what happens if I don't get vaccinated and I get COVID-19? Somebody with an autoimmune disorder is at high risk for complications, and that's not what we want to have happen. So we'd rather see you get vaccinated. None of the vaccines seem to have any particular side effect profile that's different for anybody else for people with autoimmune disorders. And I get this question in various ways. Another way I get it is, I am on, or a spouse is on biologics for an autoimmune condition. what do we need to do about vaccination? And the answer is always get vaccinated.
Okay. Shouldn't do this, but we're going to try to, with about 2.5 minutes left, we're going to see if we can flip one more in here. What are the main reasons for Pfizer announcing the need for a booster shot after 12 months? We've got about 2 minutes. Somebody want to take a shot at that?
Okay, well, I use Pfizer. We use Pfizer, so maybe I'll start it. I'll try to be super brief. We don't know how long the antibody levels last. We know they last at least 6 months. Could be much longer than that. But I think that the Pfizer CEO is particularly keying in on the fact that we all recognize that either the antibody levels are going to drop off and perhaps consequent immunity, or variants are going to be an issue and the original vaccination won't be as effective. So just the smart money is on the eventual need for revaccination, perhaps with a revised shot that covers variants better.
And Pfizer and Moderna, I think both have said there's going to be that need, and this could end up being, and you all have talked, that this could be an annual shot for a while.
I think somebody's even working on a combination shot with influenza. I had thought that would be difficult, and I think it is difficult, but I thought it might be impossible because they're very different components, very different way that they work, but somebody's actually working on a combination shot.
Okay. Dr. Thomas Huth, Vice President of Medical Affairs at Reed Health. Once again, sir, thank you very much.
A pleasure.
Dr. David Jetmore, Wayne County Health Officer. Always good to see you.
Always good to see you, Eric.
Want to remind you of something before we get out of here. Tomorrow is National Take Back Day, Prescription Drug Take Back Day. So if you have some prescriptions that you have been trying to figure out what to do with, I think from a health department standpoint, they would say, please don't dump them in the toilet or down the sink. This is a great way to get those out of your home. 9 a.m. to 1 p.m. You can take those to the Richmond Police Department, 50 North 5th Street. No questions asked. Just take your unused, unwanted, or expired drugs there. If you need more information, you can give them a call, 983-7247. So again, that's going on tomorrow from 9 a.m. to 1 p.m. The final Winter Farmers Market is also going to be taking place tomorrow. Talking about being outdoors, as of next week, that will move back to Elstro Plaza. But if you need something, need to do some shopping, 10 a.m. to 1 p.m. tomorrow. Thank you very much for watching this week's Ask the Doctors on Whitewater Community Television's WGTV Channel 11. If you missed any of this program, it will be available on our video on demand site, as well as multiple replays on WGTV Channel 11. As always, have a great week. I wish you well.